Hey, everybody, in today's episode, it's myself, Benjamin B., and Dr. T. We're talking about pain management and this new study that Dr. T pulled with an assessment that some physicians could be implementing to gauge your likelihood of developing some sort of substance abuse addiction, and that will help them determine whether or not they're going to give you a prescription for opiates. We talk about that. We talk about how you can manage your pain and ways to mitigate pain and potentially not get addicted to opiates by way of your pain. After that, we transition into some more life stuff. Tambini tells us what her favorite cereal was growing up. I'm talking about my new love for barbecue and my potential entering a competition for barbecue. We talk about all that and more. Enjoy the show. Here we are, Real Recovery Talk. I am your host, Tom Conrad. In today's episode, we've got Benjamin B.
Yo, yo, yo.
And we got Dr. T.
Hi, everyone.
First things first, thank you for tuning in on the podcast app, whichever one that you choose to use, and thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you could always reach us, info@realrecoverytalk.com. Again, that's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message. Right, peeps?
Yes, sir.
That's right.
What's happening?
Look at those socks.
Oh, we can't do socks. I already got on her about socks.
He already ripped on me. Look it's my dog.
Those are better. Those are your dog socks.
Why don't you like tie-dye?
Those weren't tie-dye. Those were grease
They
spilled.
were tie-dye. I have tie-dye everything.
Freaking hippie.
I am.
That's all right. Yeah, SoCal, right?
No,
NorCal.
Get it
Sorry.
right.
Get it right.
San Jose. What? Shout out. Mind pump. T, you got a study for us.
I got a study. We often get questions a lot regarding pain in recovery. So whether it's people who got prescribed a pain pill and developed an addiction, an opiate addiction, or people who are in recovery and they're going through surgery or other things like that, and they are either afraid to take like narcotic medication because they either have a previous addiction experience or their family members have experienced it in the past. So I think pain comes up a lot. And this study in particular has a lot of interesting data regarding pain and substance use. So the title of it is A Brief Screening Tool for Risk of Self-Medication of Pain with Substance Use. So basically, what the authors were looking at is who is most at risk for developing a substance use disorder in relation to managing pain. Because pain manifests as physical, but it's also psychological. Like how you deal with it, how you cope with it really changes your outcomes, right? So in this study, just a background of it, pain is a growing public health concern with approximately 20% of American adults and 27.5% globally experiencing pain persisting longer than 6 months. Pain has negative physical, psychological, and economic impacts. Evidence suggests a reciprocal association between pain and depression and anxiety. Further, pain related to fear and catastrophizing are more common in individuals with comorbid pain, anxiety, anger, and depression. People with chronic pain show elevated rates of alcohol, tobacco, opiate, and cannabis use disorder. And pain prevalence in people in residential substance use treatment programs is significantly higher than the general population. So 53% versus 32%. So what this study proposed is there is a screening tool that like primary care doctors can implement with their patients before prescribing pain management to them or having a discussion with people. And regarding pain, perception of pain, there's modifiable and non-modifiable risk factors. What does that mean to you guys? Modifiable versus
Duh.
modifiable means there's risk factors that we can identify that you could potentially change to help you cope with your pain better. And then there's non-modifiable. Non-modifiable are the things we can't change. So
Like it's just going to hurt no matter what.
no, your age,
Oh,
your
gotcha.
your underlying genetic predisposition, things like that. So the modifiable risk factors that this study went over for primary care physicians to implement and screening, it's called the CANUE, so CANUE, so modifiable things, right? Catastrophizing. So what does catastrophizing mean to you guys?
Like in your head, making it worse than it is. I'm glad you brought that one up first because I wanted to talk about that.
Yeah.
I see that a lot.
We want to talk about that now or after?
After.
Okay. So CANUE, catastrophizing, anxiety, negative urgency. So negative urgency is the tendency to act rashly when distressed, like impulsively just being like, screw it, I'm just going to drink this bottle of vodka and it's going to make my pain go away because I have zero coping skills. I can't do anything else. And that's the only thing that I know 100% that will make my pain go away. Right? And expectancy. So how you see your pain and your ability to say, okay, I know this is a long-term thing that I'm going to have to work at for a long period of time. And I have a positive outlook and I know I'm going to do X, Y, and Z so my expectations are met versus, oh, I should do this procedure and it should make everything better. And then the next day when you're still in a little bit of pain, a 2 or a 3, you start, your expectations go out the window because you're like, I had this procedure. Why isn't my pain gone? This is ridiculous. It's all the doctor's fault. I can't live my life like this, expectations. So those were the 5 things specifically that with this screening tool that they recommend that physicians do with their patients before prescribing any type of narcotics to them, because if they have these identified modifiable risk factors, that's going to put them at risk for a substance use disorder. And the patient needs to be aware of this so they can make an informed decision regarding their pain management.
So I have a question. Sounds great, but what primary care physician is actually going to devote the time? Because this could take an hour to go through this with somebody.
Yeah.
To find out if they are somebody to catastrophize things. To find out if their level of anxiety and what causes their anxiety. And then whatever the other ones, negative what?
Urgency.
Negative urgency. Oh, I don't know. It makes total sense. I just don't see in this world, unless it's like a
pain management physicians should realistically, I think should be part of their day 1 patient interview. Some of these questions, because I mean, it's pretty lengthy to go over here. But in the model, they use the PHQ-9, which is a depression screening tool that when in my residency clinic, we had the nurses do, because it's a quick questionnaire with the patient before they got to us. Because if they scored high on that would prompt us on their visit to say, hey, you scored pretty high on your PHQ-9, indicating depression. We need to have a conversation about it. And insurance companies actually put this as part of their metrics for reimbursement in the primary care setting. So some of these things, the GAD-7, Generalized Anxiety 7, it's a screening questionnaire as well, can be done by the nursing staff. So once they get to the physician, they already have their brief clinical history there.
Yeah, that makes sense. I mean, if you have the support staff that can actually implement these things, I think it's great. Because we talked about this not long ago, but a lot of times when people get addicted to opiates, it is by way of some sort of injury, pain. My dad's a great example. He got diagnosed with granular mitosis in 2001, maybe. And he's been on pain meds ever since. Now that's a circumstance that I don't know how you go without pain meds. He says it's like taking an ice pick and stabbing him in the bottom of his feet and in the palms of his hands. You can actually see on both of his hands, if you ever saw his hands, all in here, it's all concaved because it ate all of that muscle tissue away and stuff like that. But, he started smoking the devil's lettuce. So that took a little bit of the pain medication away, which in full transparency, I'm 100% cool with. I'd much rather him be doing that than taking massive amounts of opiates. But all to say that, that's how he got addicted to opiates. And then it, oftentimes starts with, and Ben, you could probably speak into this, starts with your typical Vicodins and Percocets and these kind of mid-level opiates, and then slowly progresses into heroin because you can't afford pills,
Well, it's like standard procedure nowadays. If you go get a root canal, or not even a root canal, you get your wisdom teeth pulled, which isn't a big deal. Root canal is pretty bad. I never had one, right?
Yeah, I've never had one either.
I've never had one, but I hear it's pretty bad. But anyway, like standard procedure for getting your wisdom teeth pulled, like they automatically give you Percocet. I remember getting that done when I was like 15, 16. I did not need Percocet. Like I felt nothing, literally.
Yeah.
I smoked a little of devil's lettuce too, even at risk of dry sockets or whatever it was. But
oh yeah, what was that dry socket? What is that?
Where you get your wisdom teeth pulled and it's like, I guess the cotton mouth like makes it scabby. I don't know. That's my medical.
Okay, yeah. You're not a dentist, so I won't ask you
I'm
that.
not.
Yeah.
Sorry.
So, but point is like there's so many, in my opinion, procedures that are done that don't need any sort of even mild opiate to begin with. But it's just become culture in the US. You walk into a doctor's office and they got the little thing with the smiley face for a 0, and at the end it's like a red mean face for a 10 of pain.
Yeah.
And like even a kid is taught to like point where they're at.
That was like part of a JCO initiative too. I don't know the exact year number, 10 years, 15 years, but like at the height of the opiate epidemic, JCO implemented this pain scale thing for hospitals and outpatient clinics. So people were hyper focused on, pain scale is a metric. It's a measure of quality assurance and how we're performing in our customer service. So you guys have to make sure everyone's happy, which is crazy because if you think about the problems that we're experiencing now, like everyone just fed into that whole thing.
Yeah. And that for me too, like it ties into the catastrophizing too. Like if I see a sign up on the wall in the hospital that potentially there's a red mean face over there, and that's where I'm going to be in my head before I'm even there in actual physical pain. Like the catastrophizing thing, a lot of times, like the way that I hear that is people have already decided I'm going to need a pain med before they've even gone through the procedure. We see that all the time at Rock. We get people here who legitimately have to have procedures done. And how often, from your perspective, Dr. T, like you have those conversations on our behalf all the time saying, no, you don't need a pain medication for that. And then you communicate with that physician. You've done that for our facility.
Yeah. I've had people fight me in our facility about it. Like, this is unethical. How could you not allow this person to have Percocets for this procedure? And I'm like, well, then why are you doing the procedure if it's not like an emergency? This is an elective procedure that you're doing for someone who's in treatment actively, and you're wanting to give them a script, even if it's just for 5 days. It shows me like you don't understand the nature of what you're dealing with. And it's unfortunate because it's people like those physicians that are going to keep prescribing pain medication regardless, even if patients are honest and transparent about who they are and what they're about, which sucks because if someone's not feeling so hot that day and they have 8-9 years sobriety and they decide to fill that script, like, was it worth it?
Yeah.
It sucks.
And then and I just know this from being here for however long and seeing these cases, but then there's like ones where, they're going in for a pretty simple surgery, if you will, and they're supposed to take a narcotic before to be able to get through it, be calm. I don't know. What's the purpose in that?
It's all we get. The biggest thing we get in this setting is dental work. And they all want to give them Valium before the day of the procedure. A 10 milligram Valium, which is, not.
Why do they want to do that? Because they're going to be working in your mouth
to
probably.
Like calm them down. Yeah, to relax everything.
And and from my experience, you're reasonable. Like you have approved stuff in the past, but it is very case by case. I've heard you say no when no needs to be said. Mm-hmm. Like, because when you look at the consequences of somebody taking a pain medication, that's what the doctor on the other end of the phone doesn't see. Like, you might be avoiding this little couple hours of pain, not avoiding it, but lessening it. Yeah. Do you know how much pain you're going to cause them
for their
down
life?
The road for their life? Yeah, it's like they just don't see it.
The other argument I get is like, I'm an alcoholic. I don't, I'm not addicted to opiates. Why can't you just let me have the pain medicine? And it's like, we've had this conversation over and over again. Outside of here, you can make, whatever decision that you think is best for you. Some people, there's different trains of thought. Some people fight me on it and say, well, yeah, that person's right. Their drug of choice never was opiates, so they should be able to take pain medicine. But there's people whose drug of choice is opiates. And so, giving them a 5 milligram Percocet doesn't seem like a lot to a physician, but to that person, it's going to trigger something inside of them.
I just want to touch on this real quick to give an example of the opposite of catastrophizing, if you will. We had a client here a year and a half ago that had cancer, stage 4.
Yeah.
Very significant. Like,
he actually just reached.
Yeah. That's what made me think about it. He's in the comment section of what, Tom?
The Sobriety Network.
Say it with some.
But that wasn't that. It wasn't there. It was on an Instagram post.
Oh, it was?
Yeah.
It was on Instagram.
But, I mean, the Sobriety Network is a good place to be. It's on Facebook. It's our Facebook support group called the Sobriety Network. Mm-hmm. And you probably heard about it by now because I put it into the episode. But make sure you go there. Facebook, the Sobriety Network.
Yep,
answer a couple questions. We'll let you in.
But where I was going with this is that while in our care, he made the decision, like, I'm not going to take narcotics. Doing treatment, getting sober, not getting back on fentanyl is more important to me than taking pain medications while going through, what was he did chemo? Chemo, yeah.
Oh, man. He's in Washington State right now.
Is he?
Yeah, doing some sort of trial.
Yeah.
Something.
Yeah, he said he was doing clinical trials.
But it just goes to show, like, what people can bear, if you will, and what can be done. That's a case where that's an extreme where I'm like, dude, if anyone was justified to take a pain medication, but this kid's sobriety was more important to him than, and
he stayed in our program too through its entirety until he couldn't really anymore. It became more of a, him being in treatment became more inconvenient for him, just because of having to go through chemo, and then his immune system was compromised and he couldn't be in a facility that had, a bunch of people at any given time. Here, you got 3 or 4 people that are hacking up lungs or whatever, and he just couldn't be in that environment. And then he had to reluctantly choose to remove himself from the environment. And that sucked. I mean, but that's a good example. And he was somebody that is a fentanyl addict, opiates, fentanyl. I remember the day I picked him up from detox. Super nice guy. Mm-hmm. But you know what? He put his sobriety first and continued to, and he's still kicking. And I really, really, really hope and pray that he pulls through this. And it's been well over a year. It was stage 4 lung cancer. That's what it was. Yeah, it was.
No, it wasn't.
Yes, it was. Well, what was it?
Lymphoma.
That had spread to his lungs.
Yeah,
Yeah, so
with lung involvement.
isn't that the same thing?
Okay. Yes, Tom, if that's what you want it to be.
I mean, he had cancer in his lungs. So
Anyways, but I think what's important about this for me is that there's a lot of modifiable risk factors, meaning there's a lot of things that people can do or learn about themselves that could put them at risk with addiction and managing their pain. Meaning like people who have underlying anxiety, depression, anger, obviously emotional lability, inability to cope with things is going to put you more at risk. It's going to mean you have negative expectations and a negative outlook on your pain. And so you're going to be more apt to the substance use coping mechanism.
Here's something you can modify too. Start exercising, straight training. One thing I've noticed here, our clients that complain about pain the most often, I'm just going to call it what it is when you look at them, they're completely out of shape. They've let their bodies deteriorate. What are the chances that those correlate? I think pretty high. You know, you might have somebody that maybe has some pain, but if they're exercising, strength training, they learn to live with it, so to speak, and adapt their lifestyle to it. But the people that I see that struggle the most with pain, where it has the biggest negative impact on their life, are the ones that aren't doing anything physically to get themselves better either.
Agreed.
Well, we've become a society of quick fixes and reaching for something that is going to just resolve or put a Band-Aid on the issue versus actually addressing the issue. I think that, and even if you look at a lot of people that enter into the treatment process that have, you know, quote unquote pain, going back to like what you were saying, a lot of it is elective. How many times do we see people come in and they're like, I need to get this done. I need to get my teeth worked on. I need to, and it's like, you've been here 2 weeks, dude. Like you were smoking meth 3 weeks ago. And now all of a sudden you want to get all this work done. And that's not to say that obviously we had a lady recently that she had an infected tooth. And then we had another lady that had some other significant stuff going on, but you know what? She went through it exactly the way that, at least from my perspective, that she should have. She did take some opiates in the hospital, and she knew that she could not be released back to us while on opiates, and she was totally cool with that. And you know, she's since transitioned back home and is on the upswing, but these are all things that people don't tend to think about when going through the recovery process, because a lot of times we don't necessarily think that it's going to happen to us, or we don't care. We don't really want to draw attention to it for whatever reason. And it's something that needs to be, I know a guy that he worked down here at this machine shop and he chopped his finger off. He worked on boats, and he built like, center consoles for boats and stuff. Birds All Marine down here off of Forest Hill. And I remember I was sitting out front the halfway house one day, and he showed up and he rode his bike everywhere. This dude was like a Florida boy through and through, didn't have a driver's license because he had like 7 DUIs, rode his bike everywhere. But he come pulling up, and he had his whole hand bandaged up, and he literally gets off his bike, and he had this little cooler strapped on the back of his bike, and he pulled his finger out. And he walks into the like manager's office and says, "Hey, I need to get to the hospital. I chopped my finger off." And needless to say, his finger was no longer able to be attached.
No.
I'm like, and I asked him, "Why didn't you just call 911?" Well, it's right here, because it was literally a quarter mile away. I figured I'd just come here and get a ride to the I'm like, okay. But anyways, he didn't take any opiates throughout that whole entire process. Now he has since passed away. He drank himself to death, but you know, these things happen, and pain is definitely real. It happens to all of us in some capacity. And it's really up to us to be able to manage it appropriately. So, well, that was a good study, T. I hope to see people implement that and take the time to actually do what's involved there. Is it already in place, or they're proposing it?
They're proposing it.
Yeah. Cool. What are you guys up to the rest of the week?
What day is today?
Tuesday.
Today's Tuesday.
The holiday throws me all off.
How was your Thanksgiving?
It was good.
Yeah?
Hung out at my sister's, hung out with the kids.
What'd you do for Thanksgiving?
Worked.
Oh, okay.
Yeah.
What'd Pierre do? Golfed?
No, what did he do? I think he just hung out.
Really?
Yeah.
Did you guys have turkey?
No, we didn't. Not this year. My stepdad cooked a rack of lamb.
Oh, okay.
Instead.
Good.
Oh, that's good.
Yeah.
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 I'm over turkey.
Well, that's what Pierre said.
I think we should have brisket.
I'm doing a brisket next week. I just did a 15-hour pork butt. I brought it in here.
Oh, wow.
Yeah. Did you like it, Ben?
It was really good. I had a pork sandwich today.
Mm.
Pulled pork,
That's
yeah.
why downstairs
Yeah,
there
yeah.
was like sandwich stuff.
You know what's better than Thanksgiving? My Sunday at the pool.
Of course. Yeah. Go
Kai
ahead,
and
tell
I
us.
Kai and I were down at the pool, and was there like probably 8 or 9 women that I've gotten to know that like take care of Kai and I. Literally brought ribeye, shrimp, chicken,
Oh, wow.
rice down, cooked it all out on the gas grills out there. We sat down at these big tables all together eating. It was nice. They're like, I'm like, oh, I got to follow my plan. Lady's like, oh, that's about 6 ounces of steak and
That's
200
nice.
grams of rice there. And I'm like, oh, all right. Yeah, life ain't bad by the pool.
You're funny. Well, that's what I've been doing. I've been doing a lot of barbecuing. So, did you have my turkey, Ben?
Yeah, didn't we have a party here?
Yeah, we had a potluck.
Oh, that's right. Yeah,
Did you try my turkey?
I did try your turkey. I think.
Did you
Must have
like
not
it?
been that memorable.
Yeah, right.
Tom, I'll give this to Tom. Tom is a grill master.
You should
That's
enter
a
some
fact.
competitions.
So,
Up in Georgia, they have some.
funny you should. They got a lot here in Florida too.
Oh, do they?
Yeah.
Are you gonna do one?
Not yet, but I've thought about it, and I do have some plans to ante up my barbecue game. I just got me a new Traeger. I got the Traeger Ironwood XL. My boy Kendrick Barbecue talked me into it. Kendrick Barbecue's on Instagram. He's phenomenal. And Matt Pittman from Meat Church. Any clue?
No idea.
He basically cooks for the Dallas Cowboys every week.
Oh, that's cool.
Yeah, he's a big barbecue guy. He's won a ton of competitions. So I get all my stuff from them. I made some jalapeno bacon poppers on the Traeger, wrapped in bacon and stuff.
Really?
Oh, dude.
Why don't you bring some of them?
Well, because they were from my house.
Jalapeno poppers.
My family eats good.
I know.
Very good. And I'm
as
gonna,
your kids get bigger, they're gonna eat more and more and
yeah,
more.
Levi's he doesn't stop eating. You know what his thing is now? And we're gonna wrap this up, but in the mornings he makes himself chicken nuggets
In the morning?
every morning.
For breakfast? Well, good
Yeah.
for him. If he's making his own breakfast, he should be able to eat what he wants.
Well, easy. I mean, my gosh, gets in there and gets whatever box of cereals available. If I hadn't gotten to it first.
That's all I ate as a kid was cereal for breakfast.
Did
Yeah.
you? What kind?
My favorite was Lucky Charms and Cocoa Puffs.
I wasn't allowed to have those.
Why?
Oh.
I got Cheerios.
Oh.
Not even the Honey Nut.
Oh, Honey Nut Cheerios are bomb.
I do like regular Cheerios now, though.
I would put sugar on regular Cheerios.
Yeah, see, I got nothing sweet. My mom wouldn't let me.
Oh,
No sugar, no.
that's sad.
Yeah.
My wife and her mom got into a argument, not an argument, but my wife's mom asked her about, the doctor told her that she needed to eat more fiber. as we all do. Well, I know I do. I'll speak for myself. Ben, you definitely need to.
Metamucil, bro.
Okay, fine. T, you're probably good.
I do. I try to hit my fiber every
How many
day.
grams do you eat a day?
At least 30 grams.
Wow. Really?
Yeah.
How?
Just food. I also do flaxseed in the morning with my shake, but I try to eat lots of veggies and I eat fruit.
You do Metamucil?
No.
That
I don't
stuff
do
is wonderful.
it. You said it tastes like Suboxone.
Exactly.
What?
Yeah, I love it.
Does it make you your gut bloated though? Do you
No,
feel like bubble guts?
not at all.
No?
No, it's you got to try it.
It tastes. I was on a little kick there for a minute, but yeah, it tastes like orange. Well, to me, it tastes like orange, and to you, it tastes like Suboxone. But anyways, they got into a little heated discussion because Amanda said, well, have you upped your fiber intake? And she said, yes. And Amanda said, well, how? And she said, I'm eating Cheerios every morning. And Amanda's like, I don't think that really counts as upping your fiber. And she's like, but the box says it's high in fiber. So I said, well, tell her to turn over the box and look at how many grams of fiber. And I think it was like 2
grams of fiber per serving.
Yeah.
And one serving's what, like a half a cup?
Yeah. Yeah. So, I would probably eat half of a box. So maybe I would get, maybe 8 or 10 servings of fiber, or grams of fiber rather. But I would also get everything else that comes with a half a box of cereal.
Yes.
So anyways, all right. That was fun. You guys done?
Yeah.
Are you done?
Yeah, I'm done. All right. That is it for this episode of Real Recovery Talk. Thank you for tuning in. In the end, if you have any comments, questions, or concerns, you could always reach us, info@realrecoverytalk.com. Again, that's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message. That is it. We will see y'all later.